Hi everyone, my name is Delora and I'm going to be talking to you guys about headache diagnosis. So before we get started here today, I have a little bit of an interesting challenge, and that is I have to make sure that you're ready to take all of your tests, to do well in your class, and I have to make sure that you understand the basics of headache diagnosis for clinical practice. Unfortunately, these things can be somewhat conflicting because what is tested is not always what's seen in the real world. So I'm going to do my best today to teach you about headache diagnosis from a test perspective as well as headache diagnosis from a clinical perspective. Okay, so let's kind of start here with a very broad overview. So someone comes in and they're complaining of headaches, and you have to figure out, is it tension headache? Is it migraine? Is it cluster headache? And this visual just kind of shows you where you can start. So if someone has tension headache, they're going to be telling you it's on both sides of their head, and it's dull, and it's annoying, and it's starting at the end of the day, and they're stressed. If it's migraine, someone's going to be saying, it's mainly on the right, it's mainly on the left, the lights are hurting my eyes, I feel very nauseous, I feel like I'm going to throw up, and I don't feel like I could do anything right now because I just feel so bad. If it's cluster, this person's going to be in extreme pain. One of their eyes is going to be red, one side of their nose is probably going to be running, the eye that's red may also be tearing, and all of their pain is going to be behind their eye. They're going to want to rip out their eye, and they're going to be restless and agitated and pacing because they're in so much pain they don't know what to do. Okay, so if you see a star on a slide in the upper left-hand corner, that means I am fairly certain that it's going to be on your Neuro 2 NBME and or STEP. Everything else is also important, but pay particular attention to those slides for your standardized tests. Now we're going to talk about migraine. So migraine by far is the most common of all of the headache disorders. So migraine can definitely happen in both men and women, but for testing purposes, they're almost always going to give you a female. And the pain is pretty much going to be on one side. So they're either going to complain of pain on the right or pain on the left. The timing, so a migraine attack lasts anywhere between 4 and 72 hours. So if it's less than an hour or 30 minutes, probably not migraine, could be, but look for a headache that's going on for multiple hours. They're going to describe the pain as pulsating, throbbing. They will say, it feels like my heart is beating in my head. They're probably going to be nauseous, if not vomiting, because your gut and your brain are connected through your enteric nervous system. So your gut knows whenever your brain is unhappy. Light and sound are going to be very bothersome to this person. We call that photophobia and phonophobia. So they probably want to go lie down in a dark room. They would not want to go to a rock concert because it would really hurt their ears. They'll probably have a hard time with activity, like climbing up a flight of stairs, something that would probably not normally bother someone, could bother someone quite a lot when they're having a migraine attack, and it could make their pain worse. And when you ask them about their pain, it should be moderate to severe, meaning if you say, rate the pain for me on a scale of 1 to 10, they should be saying 5 or above. So this is a more technical criteria for migraine, coming from the International Classification of Headache Disorders 3. It's something you can reference to more specifically diagnose migraine in a patient. It's definitely more than you need to know. You don't need to have it memorized by any means. The main thing to notice here is that a person with migraine doesn't have to have all of the things that are typical of migraine. So under C, you can see that it says at least 2 of the 4, and then D, at least 1 of the following. So just bear in mind that not every migraine patient will have every one of these symptoms. So here we have a practice question. 23-year-old female is coming to your clinic complaining of headaches. She's had headaches since childhood, but recently they've become more frequent. Her headaches last for 6 to 7 hours. She's got nausea. She rates the pain as a 7 out of 10, and she normally lies down to sleep. Her neurological exam is unremarkable. So here I have put in red the things that should tip you off that this question is telling you this person has migraine. So 23-year-old, she's pretty young, she's a female, she's having headaches since childhood. They're lasting for 6 to 7 hours, so more than 4 hours. She is nauseous. She's rating the pain as 7 out of 10, which is moderate to severe, and she usually lies down to sleep, probably in a dark room, which could definitely imply that she's having some light sensitivity. And then very importantly, the neurological exam is normal. You would be very concerned if the neurological exam is not normal, and it's also probably not migraine. Okay, so now we're going to talk about migraine with aura. So aura is a visual or other sensory phenomenon that can happen around 5 to 60 minutes before the onset of the actual head pain. So a question stem will normally say something like, before their head starts to hurt, they see something in their vision, they have tingling in their fingers, they have ringing in their ears, they can even lose their ability to speak. So some kind of sensory sensation that is occurring before the headache. So here's the more in-depth diagnostic criteria. What really stands out to me more than that on this slide is just this photo that I found that someone illustrated of what it's like to have an aura. So this is, as if this was your eye. This is kind of like what people see. So if you can just imagine, what if you were driving and you started to have an aura? Or what if you were in the middle of taking a test and you started to have an aura? There's even this super interesting video on YouTube of this reporter who has migraine with aura, and she lost her ability to speak on national television, and that's how her aura presented. Most of the time it is going to be visual and test questions, but in real life it can be any of your senses. It can be ringing in your ears, it can be anything, and it can be quite bothersome. The main thing is just it's coming before the headache, it's lasting 5 to 60 minutes, and it's kind of gradually spreading and getting worse over the time that you have it. Okay, so practice question. 26-year-old female presents to ophthalmologist complaining of flashing lights in her vision. She says the flashing lights last for around half an hour and are followed by throbbing head pain on the right side of her head. She sometimes gets the head pain without the flashing lights, and her eye exam is normal. So important things here. This still has all the same characteristics of migraine that we've already talked about. Plus, they're probably going to give you something that is visual in the question stem that's happening before the headache. People that have migraine with aura do not have to get aura with every single headache, but for the sake of test taking, if they want you to put migraine with aura or understand that it's migraine with aura, they will give you some kind of sensory symptom that is happening before the headache. Okay, so this is just highlighting the important stuff. Flashing lights, it's lasting around a half an hour. It's followed by throbbing head pain on the right side of your head. So just cueing you off that a migraine attack is following the symptoms. So this is very important, especially for test taking. If you ever get a test question about a woman that has migraine with aura, you should very strongly keep in mind that they are probably testing whether or not you know that estrogen therapy is contraindicated. And the reason why that is because migraine with aura has an increased stroke risk, and estrogen can promote hypercoagulability. Now, in the real world, it's not actually contraindicated because the study that they did that showed this had a confounding factor, which is that they did not control for cigarette smoking. So in real life, you could put someone that has migraine with aura on a low dose of estrogen, but for testing purposes, it is always, always, always contraindicated. Never, never, never give someone that has migraine with aura estrogen of any form. Okay, tension headache. So here's some big keywords besides the fact that they have a headache. So this one is more often bifrontal, bilateral. They describe the pain as more of a pressing, tightening pain. It's going to be milder, so it should be less than 5 on a pain scale of 1 to 10. It can be longer, lasting days at a time. It can be stress-induced, and they're normally not going to complain of other symptoms like nausea or vomiting. It's just going to be like a mild aching headache. Okay, so here we go. This is the criteria. On the left, I have episodic criteria. On the right, I have chronic criteria. So the difference between episodic and chronic headache is that episodic headache would be causing head pain on less than 15 days a month, and chronic would be causing head pain on more than 15 days a month. It's the same thing with migraine. So episodic migraine, less than 15 days a month. Chronic migraine, greater than 15 days a month. I have never, ever seen this be tested. It's just important for you to know for clinical practice. Okay, practice question. 35-year-old man, I don't know why, but most of the time they test tension headaches in men, presents to your clinic today complaining of tightness in his head and neck. Recently started a new position at work. It's been very stressful. Around 4 p.m., he feels this bilateral tightening pain in his forehead and the back of his neck. The pain is a 3 out of 10. It's a nagging pain he can continue to work through, although it's bothersome. He doesn't have nausea, he doesn't have vomiting, and his neurological exam is unremarkable. So, big things here. Tightness. He's stressed. It's starting in the evening time, kind of after he's had a stressful day. It's bilateral. It's tight. It's not excruciatingly painful. It's just kind of like a low-level, bothersome head pain that doesn't really have any other associated symptoms. Okay, cluster headache. So some very important discussions that we need to have about cluster headache. First and foremost, cluster headache is one of the most painful conditions known to man. There is actually a story of someone that had cluster headache that was in so much pain, he ripped out his own eyeball. So very, very, very painful condition. It's also very rare. However, despite it being exceedingly rare, they love to test you on cluster headache. So it's almost always going to be a male. He's going to be in severe pain. He might be showing up to the emergency room. It is only on one side, no exceptions. You're going to have some kind of drippage or runniness from somewhere. So lacrimation from the eye, rhinorrhea from the nose, conjunctival injection. Basically, they're going to have a very red eye. It's predictable timing. Often it's in the middle of the night, and they are restless. They cannot hold still because they are in so much pain. So they will be pacing back and forth because it hurts so bad. The other very important thing to understand about cluster is the timing. So people that have cluster headache, they go into these cluster cycles where they will get multiple attacks within the span of a few weeks or a few months, and then they have just months at a time where they have absolutely no headaches. So this could be confused with another headache condition potentially. So you really have to make sure that you have extended periods of time with a ton of headaches and extended periods of time without headaches at all. If someone comes into your clinic and tells you, hey, I've been having multiple headaches in the last week or the last month, that doesn't mean that they have cluster headache. You really need to see a very long period of time with no headaches at all, and then a pretty long period of time with very frequent headaches. So kind of as we read this practice question, I encourage you to think about the picture that I put on the previous slide, just to kind of have a good visual idea of what this looks like. So you have a 37-year-old male. He's coming into the ER with severe stabbing pain behind his right eye. It woke him up at 2 a.m. He was feeling better after 45 minutes, and then the pain began again. Ibuprofen did not help his pain. Several months back, the patient had similar episodes of pain that resolved spontaneously after 3 weeks. Patient denies blurry vision, fever, nausea, vomiting, but does have nasal congestion, which he attributes to his seasonal allergies. His sister has migraine. Vitals are all normal. The patient appears restless and agitated. On exam, you see ptosis, meiosis, and rhinorrhea with a normal neurological exam. What would you think of? Okay, so let's work through this question and the important details. Firstly, I woke him up in the middle of the night. Secondly, he's having this attack that lasted for 45 minutes, so this is too short to be migraine because migraine attacks have to be at least 4 hours, and then the pain stopped and then it started again. The other thing that is really, really important here is that he's had similar episodes to this that resolved spontaneously. In a normal headache disorder, your headaches do not resolve spontaneously, and then after some time, they come back and they're just as severe as they were in the first place. That screams cluster. The other thing they try to do is they try to get you to falsely attribute their nasal congestion, their rhinorrhea, their lacrimation to allergies, or maybe they were recently sick, and you can't fall for it. If it looks like cluster and it involves any kind of nose running, eye running, anything like that, it fits into the picture. Also, do not be fooled by the fact that his sister has migraine. Headache disorders run in families, yes, but it's not necessarily the link of, okay, well, if someone else in the family has migraine, then he has to have migraine too. It absolutely happens where someone in the family has migraine, someone else has cluster, someone else can have a different type of headache. So do not be fooled if they tell you that someone with cluster has a family member with migraine. That does not mean that they have migraine. The other super important thing is he is restless. These patients are going to be pacing back and forth because they're in so much pain and they cannot hold still. Okay, idiopathic intracranial hypertension, otherwise known as pseudotumor cerebri. So this is a very nuancy headache condition, and I'm really not sure why it is so heavily tested, but it is very heavily tested, and I can almost guarantee that you're going to see a question on it, so we're going to go over it. To help you kind of get a basic understanding of what this is, you can think of it similarly to hypertension, just in the brain. Okay, so keywords: it's a woman, probably a younger girl who is overweight or obese, so a BMI that's going to be over 25, and they will have papilledema. They should absolutely give you a BMI and papilledema if they are going to test you on this. I have never seen a question where they do not give you those things. So what in the world is papilledema? So I've put in some pictures here, and you can see on the top left, this is a normal looking optic nerve, and then the bottom left is going to be papilledema. And you would have to have a special tool to look in the back of someone's eye and actually see this in real life. But in a question, they're just going to tell you that they have it. So kind of looking a little bit at what it is, you can see from this middle picture that their cerebral spinal fluid is just kind of building up, and there's a lot of intracranial pressure, kind of the same as hypertension. There's a lot of pressure in your cardiovascular system, and it's enough pressure that it makes your head hurt, which is why you have a headache. So, practice question. 16-year-old girl presents to the neurologist's office, new onset headaches that are keeping her from attending school. Her BMI is 28. Papilledema is seen in both eyes, and her vision is otherwise normal. Her opening CSF pressure was 300 with normal CSF contents. Okay, so importantly here, these are new onset headaches. These are not headaches that she remembers having since she was a kid. It's keeping her from going to school, so it's somewhat significant. Her BMI is over 25. You see papilledema in her eyes, but no other visual abnormalities. And then CSF opening pressure is 300, which a normal pressure is like under 20. So this is very, very high. This is just a graphic that further explains a little bit more about what's happening. You definitely don't need to know anything more than young, obese female with papilledema for testing purposes, but if you're interested, you can just look at this for the purposes of better understanding what IIH is. So we can kind of see that you just have this intracranial pressure that's up, and then because it's so high, it's not draining as well, and also you're producing more CSF, and your lymphatic drainage isn't doing so well. And there's a possible link to obesity as well as the female sex to kind of precipitate these factors. Well, there you have it. This is the basics of headache diagnosis, all the things that I think could potentially come up on your test, and probably the basics of what you need to know for clinical practice. Of course, there's so much more that we didn't have time to talk about today, but if you have any questions or you're interested in learning more, you can feel free to email me.